you come and book a case at the hospital, every team needs to be the A team because there are no B-level patients.
I've been very verbally anti-hospital for the last 5 years.
What was scary to me when I moved from academic to this smaller, riskier project is I took a bunch of people with me. I really needed to create a good home for them because they took a leap of faith with me.
When you see something that could be a really easy fix that could generate more revenue, it's like moving a mountain.
We have to have a balance of what's reasonable and what you're willing to do and the amount of pain that we need to input in order to make the system better.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Work isn't your life, but it is part of it. With locum tenens, there's a way to never work weekends or to only work half of the year. You could have a job on the coast with fewer hours and more pay, or work just down the road and have a beautiful work-life balance. Create the life you want with locum tenens. Explore your options at locumstory.com. No commitments, no recruiters, just resources.
Hey guys, welcome to another episode of the Life of Flow. Today we have Dr. Kristofer Charlton-Ouw, who is the vascular surgery chief at HCA Medical Center here in the downtown medical center area in Houston, and somebody who I've been now working a lot more closely with, and I think has a lot of really interesting things, from building a program to maximizing resources to flying a plane. So stick around. It's going to be a fun 1 hour conversation. Hopefully the first of many more in the future. Vámonos.
Hello, everyone. Welcome to another episode of the Life of Flow podcast. And today we're going to have a banger. We have Chris here from the Houston area, one of Miguel's close friends and colleagues. So welcome.
Welcome, Kristofer. We did a longer intro on the top of the show so people know a little bit of what you're up to. We've been certainly working a lot more together lately since I've joined the HCA family in the Med Center area, and it's been really an awesome time. And I extended this invite because we love it. It's funny, but in a very selfish way. I don't get to have you for 1 hour to know about you, right? We're always running. We're doing cases. We're talking about work. We're on a Zoom call trying to figure out how, device procurement has to be improved. But we never have a little time to just talk and learn about each other. And so I appreciate your willingness to come and put yourself out there to have us dig into your life a little bit and understand more about what the more known as KCO is all about and how you tick.
That's a great acronym, by the way. I need like a cool acronym that people call me like that.
It's just my initials, so it's not that cool, but yeah, it's been really great working with Miguel, and I appreciate him taking on my fellows, teaching them. I think they learn a lot from him, how he runs his practice, and just kind of how he organizes his operating room. I think it's been really mutually beneficial for both of us.
Lucas is a victim of that too. Lucas was one of my Baylor fellows, and we became very close. And obviously today we're really good friends. But it came from those
Chris,
times.
do you know Miguel's like parting graduation like farewell message to me, like on the graduation day?
No, tell me.
It was a picture of a groin hematoma saying, "Look what you did to my patients." Goodbye.
Right.
That's why he sent me. Oh, that's kind of on brand.
Right.
Congratulations, man. I hope you never do this shit.
Yeah, to your own patients, right?
Thanks for doing that to mine.
What was the idea? Who had the idea of working together?
That's a good question. I'm not sure where it came from. I knew Miguel had moved to private practice. I'm not sure exactly how much he was doing at Methodist or other places. And I'm not sure who reached out to whom first, but I kind of had the idea that, hey, look, I want to make this a good place to take care of vascular patients. And this is HCA Houston Med Center I'm talking about. So, and it's weird because I moved from, one of the big, I think Miguel and I both came from very big 1,000-bed hospitals and the Texas Medical Center, and we both moved to much smaller places, but right under the nose essentially of it, right under the canopy of, this huge medical center. But I think for both of us, we were looking to create something that was really patient-centered, and we wanted to create a place that was perhaps a little bit friendlier with a different vibe, a different feel than sort of, I do feel like the med center is missing certain things, and I found it very hard to effect change in those big systems. And I felt like I had a lot more influence in this smaller hospital that, essentially didn't have vascular surgery, but it was, in a way, it was kind of a clean slate. And one of my things, especially in reaching out to Miguel, was he does stuff that I don't do. And I want to take complete care of the vascular patient. And I think it was just a kind of a, uh, it was kind of a win-win situation for both of us that, hey, look, I have this full service inpatient hospital program that we're creating. He has this kind of slick outpatient program. I think it would be really beneficial for our fellows. And then slowly from there, it kind of grew to, hey, why don't you do your cases here? I'm happy to, we're happy to round. I mean, look, here I am on a Saturday. I just rounded on all the patients, but look, he has a lot going on, outside of the hospital necessarily. His focus is in his office-based practice. I'm here rounding anyway. Why don't I just see his patients? I'll happy to round. We have residents and fellows, and they participate. They learn from him during the cases, so it's only reasonable that they round with me on the weekends. And so it's just been one of those things that kind of grew from there. Like, hey, let's just see if we can't work together, kind of synergistically.
Yeah, I think I was the one that reached out. I was in a situation where, it's very good in general because I was at Methodist and things were really going well. But Methodist has a large physician organization with a huge amount of vascular surgeons. I want to say there's seven or eight. And I was the private, kind of solo cowboy there. And it's hard when you have that much volume and limited resources, to be able to find your place and to find the appropriate support. As it was a good time where, I was feeling, um, that I was having a lot of trouble because the hope amputation prevention idea had really started to grow. We were in year 4. We had already opened 3 offices. We want to open a 4th. I can't be in all these places if I'm trying to build a grassroots effort. And KCO was incredibly, um, kind, to say, you know what, we've got resources, and why don't we figure out how to work together? And I think one of the things that I loved about it was that he said, here's where you step on my feet, and I don't want you to do this, and I'm okay you doing this, but maybe not that. And I said, that's perfect because it aligns with what I need to do. And as long as you don't feel like I'm dumping in any way, shape, or form, that was it. And I'd say after that, every single interaction has been amazing. And here's, you're gonna find this incredible, Lucas. And I don't want to make this about me in any way, shape, or form. But I've been very verbally anti-hospital, for the last maybe like 5 years. And I'm gonna tell you that I am starting to get this itch to be more involved and to be part of change. And believe it or not, I'm not obligated to get into like section meetings or anything. I'm like, where is the section meeting? I'm trying to join the call. I'm listening in. I'm trying to, because what Casey has done is really cool, is in the heart of the medical center of Texas with that history, right? With those, museums and the big, shoes that have been there. He said, like, you know what? Let's start, like in a small hospital. We're going to build a kick-ass program from the bottom up in a way, and we have great corporate support. We have good doctors. Why don't we do something where it's physician centric and it feels physician centric, and that's what it's felt like. Like it's small, but it's so good. It's the same people. Every time I go, it's the same people. I felt like I would never scrub in with the same people before. It's the same ORs, it's the same product lines. Like you're building these, so it is different when having a smaller hospital than a huge hospital. Yet you're doing thoracoabdominals, you're doing advanced DVAs, you're doing carotid disease, you're doing arch reconstructions. So there's like nothing that's not happening there, but it's just in a less smaller scale production, which allows for a much more personal program. But but uh, but but I would like that to be more than what we've been able to create. Is I want to hear from you when you decided to get into this program. What were you thinking it could be? What did you like? What was your mission? What was your vision of it initially when the opportunity presented itself?
Yeah, I mean, I think to kind of dovetail on some of the points you made, one of the nice things about working in the med center is I recognized how nice it is to work with a group of working with the same, not having a different OR scrub tech every time, not having a different anesthesiologist every time, because there's a lot of stuff that we do that, I can't teach the fellows or the residents and my scrub tech the name of how to hold and pass a Castroviejo, needle driver or whatever. I can't show them how to load the needle because it distracts from the case. So it's good but you can't have just one. You can't have one team because that team needs to go on vacation and needs time off, and you can't have it run 24/7. So you need a team. And so we kind of, it just made sense to morph into having a CV team. And I use that word a little bit gingerly because I think cardiac surgery and vascular surgery really work. There's a lot that we can leverage from them, but that we often get confused with them. So I use it sparingly because I don't want to use the word cardiac and cardiovascular in the same word, because we often get subsumed. People just assume we're heart surgeons that can't work on the heart, but that's not it at all. It's a different specialty. And so, but at the same time, we use the same instruments with the same names and things like that. And so there's a lot we can leverage off of it. So when you come and work at HCA Houston Med Center, you're only working with the quote unquote CV team. And we have about 5 teams. And we need that number of teams. There's no way that I can have 5 teams to myself. I can't run 5 rooms. I can't run 4 rooms right at the same time. But we can run a room in the cath lab, because a lot of the times in the cath lab, they're doing these, kind of structural heart things that require an OR team, like, a TAVR, transaortic valve. Cardiac surgery can run 2 rooms. You and I can run 2 rooms, right? So all of a sudden, we have this team of specialty specific or reasonably specialty specific focus on cardiac and vascular surgery. And it's the same group, and we rotate. So there isn't a vascular tech, there is a CV. And when they take call for all of us. And so they all rotate. So there isn't someone that's just specializes in open hearts or an endo. You have to know both. And that's been difficult to train. But now that it's in the culture, it really works out for everybody, because the people that, oh, I don't like the wires and things like that, they end up liking it, right? And especially if you get to know it and understand it and get good at it. And so what that means then is that when I take call, I don't have to work with the on-call person doing gallbladders, right? I'm not just in the main OR and, oh, okay, the on-call team is, team B, and they are the same team that does the gallbladders as is doing my, ruptured aneurysm. They can't be the same team. You have to have some sort of specialization amongst the scrub techs, the nurses. And so that's been a really important component of what we're trying to build, is that when I put a case on call, nights or weekends, or even during the day, I can't have a gallbladder team or the person doing a hernia, and that's what their specialty is. No, they have to specialize in vascular. And that's kind of what I learned from being in the medical center for all these years, is you can't just have, I mean, to be on call with just the regular main OR team, it is so painful. Yeah, you want to shoot yourself in the head sometimes because, and you don't know who you're going to get, right? Whereas with the CV team, there's a breaking in period. You don't take call until you've done a couple cases with me under supervision during the week, during the daytime.
There's no buy-in from the random team. It's a culturally, the energy in the room is completely different from a team that has no buy-in to vascular than a team that does.
That's right. That one of my other hospitals, one of my colleagues, I hired him just out of training. So he was essentially a first year attending, and his first independent case, so the first case he did without me, not his first case, but his first independent case without me, was a fempop bypass. Perfectly reasonable case for, a first year attending to do. And of course, one thing led to another. His case got delayed, and all of a sudden the magic, 3 p.m. happened. And who did they give him? A scrub tech who was brand new that had never done vascular. And that's who he did his first case with. Imagine the stress level and imagine the care. So of course the case took way longer than it might otherwise have. And he's distracted by it, right? Because, he doesn't know that they don't know the names of the instruments, how to load the needles, and all kinds of stuff. You don't realize how specialized it is. What an awful experience that was for everyone, right? And so that kind of stuff, that's not good care for the patient. That's not the kind of care we want to deliver for the patients, but also for the physicians, because it's miserable, right? So that's, Miguel, when you come and book a case at the hospital, you shouldn't have that. You should have the A team. And there shouldn't be a B team. Every team needs to be the A team because there are no B level patients. Every patient needs to be an A level patient. So that's part of what goes into the culture. You have to switch that to you can't have, so we separated entirely from general surgery, and we are a separate department now with a separate OR team. And so when I don't really care, I don't really know what happens in the main OR, and it's a separate call team. We have nothing to do with them. Now there is a downside, and that downside is, look, the cardiac surgeons may have a type A dissection going and they're using the call team. And so I think what we need to work on now, and they just hired a heart transplant surgeon. So, but as we build and grow, I think we're going to need a backup call team now, right? But those are the growing pains that we're going to have to deal with. But at least no matter what the team is, no matter the time of day, I feel confident that the team that we're bringing in, we can do whatever case, we're posting, because they've done it with me during the week in an elective situation, so that they're much better able to handle the emergency situation.
So where were you in your career before you took this job, and what goals did you have, and is this something that was in your goals or that just came out? And
This came out of struggle, right? So this came out of not having a good system all the time, and yeah. So I did not plan all this exactly. If you had told me 15 years ago this is what you're going to be doing, I was like, I'm not sure that's exactly. I had kind of a standard academic career goals. I wanted, you sort of work through as assistant professor, associate professor, full professor, and then, I want to be the lab director, the program director, and then the division director. So you sort of have goals mapped out, and my goals definitely have changed over time. I'm not, and so I went to med school at Harvard. I did my fellowship at University of Texas in Houston. I was a junior attending there, slogging it out, getting all the kind of quote unquote crappy cases. And those crappy cases often turned out to be cases my senior partners didn't want to do. And those cases were things like infected aortic grafts, all the redo cases. And so I ended up getting those. And they always came, when you were on call. And they sort of slid down to me, even if I wasn't on call, like, here's an infected graft for you to do. And so, but that sort of shapes your early career, that I ended up being the infected graft guy, and we ended up, doing a lot of redo cases. And so you ended up having kind of protocol. And so, we have a protocol now for infected grafts, and we just did an infected TVAR done in Austin, got transferred to us. We resected the TVAR, and, it's just like, look, I know it, like, even if those cases are tough, but having a system and here's what we do, like, or we're gonna now we successfully resected it, now she's gonna get antibiotic beads, and you tell the patients that this is my protocol for it. We put the antibiotic beads in, and the reason why I know why I use antibiotic beads, because I did research and we published on it, and we looked at our antibiograms and looked at, one of the interesting things about doing research is that you sort of look at your own numbers, and the antibiotics that we were empirically giving patients were wrong 20% of the time. but you don't get the culture data until after you've often resected the infected endograft. And so we kind of changed our antibiotics and the antibiotic combination that we put in the beads. And we did basic science research with microbiology. We plated little beads and looked at all the antibiotics and which bead combination worked better. So to come up with, but those are the things that you're not really going to do unless you have the cases and the volume for it. And so I think my early career definitely shaped my career now in ways I couldn't have predicted. And I think that's the kind of interesting, fun thing about medicine is, it's very flexible and it can change over time. And I'm sure Miguel was doing similar kind of cases when he was, at Baylor. And, he kind of changed gears into primarily outpatient practice. And, that's an incredible, awesome thing about vascular surgery, that we're able to pivot and do those things. But, I, as a vascular surgeon, I have never done a single case as an outpatient. I've never done a single case in an OBL, right? And I've always been a med center surgeon. And that's just the kind of surgeon that for the time being, that I like, right? And until I maybe decide, hey, I've had enough of, taking call and working nights and weekends, until that happens, that's the kind of practice I set up. And that's the kind of practice I'm focusing on, is being able to take care of complex inpatient vascular work. And I think Miguel and I both recognize there's a definite need and a place for efficient, good outpatient vascular care. But we also, some percentage of your patients are going to need inpatient care at some point. Some of them, hopefully not a lot of them, but some of them. And there has to be a place that can take good care of them.
Yeah. What if I'm, I'm not sure if you've ever sat down to put it in words, but if I would put you on the spot and say, what do you think as of today is your mission with this project, and what do you think is the vision? So what would you like to build, what would you like it to be today? And if you could put a wish list, in the best case scenario, where would you like it to be, let's say in 10 years, with obviously all the work you're putting into building a program from ground up?
I think I'd like to create a place where it's, number one, focused on patients and so that patients have a good experience with it. And that's harder than one thinks, because, the things that patients complain about are not the things, I have to do a lot of service recovery when it's like, oh, they got the wrong food order. What control do you and I have over, like, what food order comes, right? Or the cleanliness of the room, or the nurse in the middle of the night, woke me up, and, like, we don't have control over those things. But yet that really affects how patients view the hospital system, right? How good our office front desk staff is. And, a lot of times, look, I'm an employed physician. Like, I don't always have control over who answers the telephone when they call, right? And so, but those are the things that patients notice. And so I've had to pay a lot of attention to those kind of details. And I spend a lot of administrative time saying, hey, man, we got to have the rooms clean, and we got to have, I can't have you can't put my patients in the old rooms. I need them to be refreshed. Right. And so those are the kind of things that we spend administrative time on. And so if you ask what I'm surprised at, or the vision that I have is, look, I want the patients to feel like they're getting good. I want them to actually get good care, which is very different than their perception, because a lot of the good care happens in the OR and they're asleep. They don't see that. But all the other things, like, hey, the food and the cleanliness of the rooms, and, all the things that we don't have that much control over, that's a lot of stuff that they do see. But I think I recognize the importance of that. So I want it, number one, I want the patients to have a good experience, and I want our patients to get excellent care. And that means good systems of care, having call teams and having ERs that work, and ICU care that's good. And also having good ancillary care, right? We need good hospitalists and good podiatrists and good people taking care of all the things that, that affect their care. But number two, I wanted to create a system that works for us. You and I, Miguel, Lucas, like, when we bring a patient to the system, I don't want to be miserable there. And I don't want to, if I post an emergency case, I don't want to, like, have to wait 6 hours to do it. And then I'm doing this sort of urgent case, at midnight. right? So there has to be good systems of care. And it also has to be, look, we need good turnover. I want to be home at a certain hour, right? There's no point in me booking a bunch of elective cases and just, the turnover being bad and, we're not getting the supplies that we need and things like that. We have to have a good quality of life too. And so that's also important because I think that also affects the quality of care that I deliver. And it has to be good for our staff, right? I don't want our staff to be miserable because indirectly that's going to make us miserable and the patients miserable because if the staff isn't happy, they're not going to be able to deliver good care to our patients, right? So it has to be good for everybody. And that has been very challenging also, right? Trying to make sure that our staff has the resources they need to do their job. So it's kind of weird. I mean, I didn't expect to be in this position of trying to do all those things, worrying about the quality of the food and, how good or bad the registration process is downstairs. But those are the kind of things that seem to upset the patients. And some of the things that upset my colleagues, are things like, look, the OR start time. We can't promise you an OR start time of 7:30 and then you're in the room at 8:30. That can't happen, right? It's not fair to you when you book a case. But so it hasn't been a smooth process, but that at least is the goal, is for all of us to have a good quality of life, patients, staff, and providers, surgeons.
My perspective from the outside as somebody that's just starting to engage in the system is I describe it as almost like a concierge cardiovascular, like very high level facility. That's what I feel like it is. There's not a ton of beds. I mean, how many beds do we have?
166 active. It's licensed for 330, and so they are actively, when I started, there were about 70. So we've doubled the number of active beds, you know, since I started 5 years ago. But it's still, look, each bed costs over $1 million for the hospital. So when they open a pod of 12 beds, they need, $15 million, right? That's $15 million of capital and everything else, right? So it's way more expensive than that you and I would have probably thought. So it's been, look, hard, right? Because this went from a money-losing hospital to a money-making hospital. But look, you have to convince the administration that I can fill those beds with, profitable patients. So they don't want to invest the money. They're not going to build me a whole new tower, for $100 million just off the bat, right? You have to show growth and look, I'll say that there has been investment. They are opening new beds. They are opening pods. We're working on getting a vascular only pod just for vascular patients. But you have to have volume and you have to have consistency to do that.
One of the observations, Chris, is that I've made, especially in my last job, was that the incentives between the surgeons, the practitioners, and the kind of more down the chain administrators to the up chain administrators, all the incentives are different and they're kind of siloed. So when you see something that could be a really easy fix that could definitely generate more revenue, bring efficiencies, to have a really easy idea that would be a low capital expense, like $25 an hour person for like 6 hours a week. It's like moving a mountain, moving them. And the logic is there. Like if we invest here $25 an hour, you will get like 10 times returns in like capturing this type of information or whatever, usually in coding. But and I could imagine how that disjointedness and incentives affects the whole thing. So how do you manage that? That's the one thing that I'm like, uh, I really don't want to spend time in my life dealing in an organization that the incentives are not aligned. And for me, incentives are patients being taken care of the most efficient way so we can take care of more patients. It's kind of pretty simple. But yeah, how do you manage? Do you observe that? Is that something that do you think I'm off the mark or?
I think, Lucas, that is one of the most insightful things I've heard. You're 100% right. And it took me a lot longer than it took you to reach that point. So you were probably a lot more insightful than I was. But I would say that that is 100% right. And I spend a lot of time trying to figure out where everyone's incentives actually are. Like, what makes you tick? And that goes from my practice manager, that goes for the hospital administration to the nurses, right? Because you just have to understand what makes them tick. And not everyone's forthcoming about that. So, HCA or the current hospital system I'm in, I think they are not. When I was at a nonprofit hospital in the med center, they were almost proud of their nonprofit status, but at the same time, the interesting thing is the incentives for the administrators were very similar. It didn't make a lick of difference whether they were not-for-profit or a for-profit hospital. And many of them, these administrators, they bounce around from hospital system to hospital system. So the sort of nonprofit administrator may have they kind of cut their teeth at Ascension or Tenant or one of these big nonprofits, and they moved here for, because they got a promotion and a job. And their incentives are not different at all. And so you're 100% right. It's very important to figure out and align yourself with their incentives, because I think you'll get farther. And so I spend a little bit of time when I'm talking to someone influential in the system about figuring out what those incentives are and figuring out ways that we can align. And it's much easier to get things done. I'm not saying it still takes longer than I wish it would, to figure that out. But yes, that alignment of incentives is critically important and to understand. And it's funny, they don't tell you these things up front. I'll give you an example from my outpatient practice. It's a small example. I have a perfectly healthy outpatient practice, but my administrator was like, you're just, we can't hire the staff that you want us to hire because you're just not seeing that many patients. And I was like, wow, I'm so busy. How is that possible? And I'm not seeing, and so I just struggled. I was like, I don't think it can work here at HCA because if they're telling me I suck and I'm not seeing that many patients, I'm exhausted. I'm going to turn my phone around. You can see this. It's almost a little embarrassing, but this is the pile of notes that I have to do. There's probably 200 charts that I'm working on here. And I'm actually not on call, but here I am at work because I've got all these. And how is it that I am not seeing enough patients, right? And the administrators my practice manager's like, we have to open new clinic slots because we have a waiting list that's, 2 months to 3 months long. That's not good vascular care when the waiting lists for some of these. So how is it that I'm disconnected? What's the disconnect? And here's the disconnect. I was not billing for 99024. I don't know if you guys remember that code, but that is a postoperative visit code, right? So if I see in the hospital or in my outpatient practice a post-op patient, that is associated with like no RVUs, no billing, right? So in my academic practice, I just didn't put the code in. I was like, well, that patient's within the global period, right? But that's probably 20 or 30% of my patients are patients that I'm seeing in the hospital every day. I'm of course seeing them mostly because I've already operated on them, right? And they're just in the recovery period. And then there's a 3-month global for all these patients that I see as an outpatient. But I wasn't like quote unquote billing for that code. Well, we figured out that the hospital system, their metric is not their metric as the outpatient is not how much revenue I bring in. Their metric is patient encounters. That's their metric. So they use that for their staffing level, but no one told us that. No one mentioned that to me. And a lot of the metrics for the leaders were how many new patients I'm seeing, right? And how many, what percentage of existing patients made a follow-up appointment the next time. Those are their metrics. So all of a sudden we figured this out and we start putting in 99024 and I bill for it, quote unquote bill for it. I don't get anything from billing for it, but all of a sudden they're like, wow, you're doing great. Do you need another MA? Do you need another MA? Do you need another front desk person? And now I have a staff of 11 because I put in these codes and with exactly the same patient care. And it seems obvious to you and I. It's 100% obvious to you and I. Obviously, of course, why would they care about me putting in this non-billable code? But you have to understand the incentives for every system that you work in. And for them, it was patient encounters. They couldn't use revenue. They don't use revenue in my outpatient system. Now, the hospital, when I told them, like, look, I suck. I'm not seeing enough patients. I'm slow. I don't write my notes on time. I guess I can't make this work. They were like, what are you talking about? Like, you're profitable. But you would never know that from my outpatient, but you would never know that from the outpatient side because they don't talk to each other. So one set of administrators has a different incentive than the other. So the hospital is like, yes, bring us revenue generating cases. From the outpatient side, they don't see the revenue from the hospital. All they see are patient encounters. That's what's important to them. And so you are exactly right, is that when you are trying to develop a system, when you talk to each one of your kind of stakeholders, you have to figure out what are the incentives. And look, I helped them help me because I'm complaining like, look, I can't do this with just one MA with one front desk person, right? I'm too busy for that. But they were like, we can't help you because you're not meeting our metrics. It was only until I figured out what their metrics were that we were able to come together. And so you're exactly right.
But that's what brings misery to our lives, because then we have to placate these crazy things that don't make any sense by doing more work, by doing more menial work. Now I have to fill this paper. Now I have to do this thing. Now I have to take this. And then you're adding things that bring no value, that don't make patient care better, but that placates like someone
But Lucas,
that went to business school. It's
you were
crazy.
seeing these patients anyway. So the hard
Yeah.
work is done. Me clicking 99024 and, to bill for that note added seconds. It was no big
Yeah,
deal. And
but it happens, if it happens 200 times and it takes 10 seconds, then that multiplies it. And then that's not
yes,
just that one thing. It happens in multiple different levels
that's right.
200 times again. So it
That's right.
adds to our misery for sure.
That's right.
Let me tell you the let me just share a story of we'll leave it let's leave the institutional name out of the story. Um but it's academic and it's in the Houston Medical Center and it's 3 letters. Anyway, um I got I got when I finally decided that I was gonna leave and I put my, I said, I'm leaving and I think I had to put a 90 days. It was the release. Um, I I remember that day I was like, I'm gonna say some truth on my way out. And that moment in Batman when the Joker's leaving the hospital and he kind of stops and looks back and then there's this explosion. He's like, okay, good. You know, it was a more fiery time in my life, please, before Lucas starts
It was
saying,
last week. It was last week.
before Lucas starts trying to make me look bad with my new boss here. But anyway, I remember being on a call where the idea was like, hey, if you're late in your outpatient notes and you haven't closed them, and it was something like if you had more than 50%, more than 14 days, outpatient notes, like these minutia, right? We're gonna cancel your clinic completely. So 35 encounters would be canceled, out of which 10 were new patients. And I thought that was the most draconian thing I'd ever heard. I'm like, you realize that it's punitive because you're essentially using my patients against me in a way to put pressure over me without actually saying, hey, you're the busiest guy of the division. You're behind on your notes. For example, here's a crazy. What if I give you a digital scribe? What if I can help you with somebody else that can help you move your notes and we're going to get you because you're so busy? No, we're going to cancel your clinics, which feeds the system. And I remember when it was 120 or 30 of us medical directors on the call. And I said, I don't think that makes any sense because of A, B, C, and D. And then that person that was, I don't know, dean or whatever, said, well, this has been already decided by people above you. And I remember I couldn't hold back. I said, well, the people above me have no idea of what they're doing and they should listen to us because otherwise, why are we spending time in this call for me to tell you how dumb this idea is and how you're using people against us, which is absolutely dumb because what we do is take care of people.
Right. And it hurts patients, right? It hurts patients when you can't there we don't do boob jobs, right? These are people with life and limb threatening problems.
And check this out. You know what happened? This was like on like day 60 of the 90. I got a demotion. They said the guy was so mad that I had spoken up and I got 20, 30 text messages from all the other guys. Like the plastic division's like, bro, go for it. The ortho guys were like, go for it, please. You're talking for the people. And on the way out, they're like, "Oh, hey, you're no longer the executive chief. You're no longer this. Like, you're gonna leave as a really low level guy on the way out." And I said, "Okay, guys, thank you. That was like such a low blow for no good reason. It was just a political wrath of speaking up for what we think is true." Now, I think now I would say there's better ways, and I think we have to learn how to dance their dance in order to exert change. Because otherwise, if we just want to, use moral compasses to get there, we just can't. We have to sit down, meet people halfway, try to understand what their incentives are in order to move the needle. Because for us, just claiming authority on a moral level, which may be true, is not enough to move the needle. And you're probably going to find more opposition than actual exert change by doing that. So I feel that there's a need for us to be emotional and fight for the right cause, but at the same time be politically smart enough to know how to get that needle moved and how to get people on your team.
I think that's exactly right. I mean, there has to be a balance between maybe Lucas's first reaction, which was, well, I mean, your first reaction is more work for me, right? And yeah, 100%. I think Miguel, that initial look, you were probably already on your way out and you kind of had that sense and you were kind of like, well, the hell with it. But if you were going to stay in that system, it's some ways it's counterproductive, right? Because you were exactly right. You got to meet their incentives. And if their incentives is, you finishing your notes in a certain window, all right, as long, I mean, look, they want me to finish my notes in a certain window also. And I told them, look, I'll get them done. And then look, you can take it to an extreme. I mean, there's plenty of surgeons. I mean, we were on some meeting and there's some surgeons who didn't dictate their op notes for 3 months, but that's bad care, right? That no one can see what happened in that OR. And so there's a balance between, look, we're not going to let you book elective cases because you have all these op notes that you haven't done. But you know what? That I get it. Like, first of all, it's really, I mean, if they get audited by, the hospitalist, by the hospital kind of, auditors, look, you can't not have op notes done, right? And just like, look, it's probably not great that I've seen patients in the office and their office notes aren't done. I mean, I got to do them, but at the same time, we have to have a balance of like what's reasonable and what you're willing to do, and also the amount of pain that we need to input in order to make the system better. So anyway, so I started billing 992024. I got 20% more office staff, so I got what I wanted. And look, yeah, that's right. Here I am on a Saturday, trying to get the notes done. But hey, that's a small, and from my mind, it's a small sacrifice. Still going to spend time with my kids. Still going to spend time with my family on the weekend. But I come in a little early and I try to get my notes done. That's the compromise.
The one thing, and maybe we move on to a more fun topic after this, is that we also get to talk about like what do we want to do with our lives, and are like what's really motivating us when we do these things. Because I also spent, I don't know how many years, 7 years, 8 years of my life in academia, and it was a really like an ego driven decision, from like, oh, I want to be in this thing that I think is like a high level, and I want to do these cases, and I want to do this thing that's prestigious. um and then at the end of it, I'm like, okay, I am spinning my wheels in a really ineffective, ungratifying way, and I'm building something for someone else. And and that's fine if you want to do it, but just like, let's just be really honest about things, and really look at what we're doing. Because when an organization gets above a certain level, it becomes its own animal, and people act from really weird incentives that I think are probably, that at one point, patient first is just lip service. At one point, it's just, I'm covering my ass, I'm checking my box, and that's what I'm doing. So, and I think that after a certain number of beds in a hospital, that's what you get, because there's some built-in human behaviors, you know, interactions that we can't change unless we change our DNA. Um, So, anyways, but maybe we move on to talking about flying.
No, but let me frame that. Let me frame that into a question because I think it's a valid question, which is KCO, you took a leap of faith. You changed what was your career projection with a specific system and a set of what you thought was these goals into a new project that's going to demand sweat and blood from you to build up from the ground up. Is there a degree of hesitation and or fear that this is a project that you don't necessarily own because you're working for a corporation? And does that ever permeate your mind and can cloud your decision making or your interest? Or is this something that you just have come to terms and say, I'm fine here, and I know that this is not necessarily like I don't have 100% of HCA ownership. So, how do you deal with that perspective?
I think we're lucky as vascular surgeons in that I always look, I have good pedigree. I look good on paper, maybe less so in real life, but on paper I look good, right? And
I think you
so
look great, man.
You
Come
look
on.
great in the camera.
I
You look way better than
always,
Miguel that just
I
put that
Way
light
always,
better.
thing
Look
on.
at me. I have
Yeah.
like eye bags and shit.
I always felt like, hey man, if it doesn't work out here, I'll just go somewhere else. What was scary to me when I moved from academic to this more kind of smaller, riskier project, as you put it, is I took a bunch of people with me. I took my MA, my nurse practitioner, my ultrasound techs. They are single moms. I really needed to create a good home for them because they took a leap of faith with me. And that was a personal, and they did it based on, like, they didn't know like the system necessarily. It wasn't like, oh yeah, that's a better system than the other. They did it because we worked well together there and they wanted to continue that working well together here, both for their careers, their own personal goals, whatever the reasons were that they came. That was stressful because I brought them from the University of Texas, which is kind of a state institution with good benefits, and it's okay, maybe, maybe it's not perfect there, but it was kind of like, you know, kind of safe, into a system that is private, corporatized, more risky. And so I was more nervous about that, to be honest, like pulling out people from a safe system and into a system that I wasn't sure about. And as it turns out, you know, I left in August 2020. That was the height of COVID. And a lot of systems in the med center laid people off. And ironically enough, HCA never laid anybody off. So that was the irony about the whole thing, is that UT laid off a whole bunch of surgeons even. There were 16 orthopedic surgeons that they laid off. Who lays off orthopedic surgeons? I thought they were like people you never laid off. And so it was interesting to learn and see what happened to my colleagues who stayed behind. The other interesting thing, which I thought was so odd that UT did, was, as I exited, um, they were a fair system. I only have nice things to say about UT as a system because look, it was very formative for me, and from my side at least, I left on good terms. But it was weird what the system did in COVID is that they took away everybody's stored vacation days, which I thought was the most unfair thing because people like me, I had a lot of unused vacation, right? I just never took vacation, right? And, or I would take a couple weeks with the kids and this and that and the other, but it was small. I would, go away on these small weekend trips. But there were some people who used up all their vacation. They would take, all their 4 weeks of vacation and they were gone. And you ended up punishing some of the hardest, most loyal workers because you took all of their stored vacation. Now, as I left, UT paid, I never agreed to that. I ended up leaving and they paid me for my unused vacation, which was 3 months of unused vacation. But all the people that stayed, especially the people that had been there a long time, had a bunch of stored vacation and they took it. And, I thought, wow. And it affected, and what a thing to do. And that kind of corporate, just like, look, we're short, we closed the ORs because of COVID. We're short of cash. We're going to take your stored vacation and monetize that and sort of say, here's how, we're going to balance the books. So it's interesting my experience between private, not private, profit, nonprofit, academic. I mean, I do research, I teach fellows. Actually, at Miguel, I really want to talk to you about some sponsored research that we're doing that I would love to get you more involved in. This is the kind of stuff I'm like, what's the difference? The difference is how you and I make it. You and I are not financially related, right? We're not in the same system. We're not in the same group. But I feel as connected to you as I did with any of my partners when we were actual partners, right? And sometimes more. Sometimes there was disalignment amongst partners. So I think it's really more about, hey man, what difference does it make what badge I have on my shirt? And more, is there alignment amongst people, right? And what kind of system do we want to create? Never mind what badge we have. Anyway, those are just my passing thoughts on that.
This is going to be, I'll keep this one as a very personal memory of you, that whenever anybody asks me, what do I think about KCO, is my answer is going to be, well, he's the kind of guy that if you ask him a very personal question about self-risk and decision making that affects his life, his family, his well-being, he actually framed it in wanting to do what's best for the rest of the people in his team, and took what could have been a selfish question and made it a very selfless stance. So thank you for making it easy for me to be able to describe you in the future, man. That was a really nice way of answering that question, really. We're about 8 or 9 minutes out from being done, and you started us with some like really exciting stuff, which we had no idea of when we said, hey, what do we talk about today? Because this is how great we prepare for our podcasting, right? We do extensive research. We have multiple people on our team, and we went through all of your historic acumens. Anyway, and he's like, what about aviation? And Lucas and I were like, what do you mean aviation? He's like, well, yeah, I'm going to be a pilot. I was like, wait, what? So tell us a little bit about where this idea came from and where you at in this journey of flying a plane by yourself. This is crazy.
So it's been an incredible year-long journey, but it goes more than that. I mean, probably for 20 years I thought about flying. It's so awesome to be in the air. The sense of freedom you get. It's like riding a motorcycle. I used to ride a motorcycle, but my kind of wife was like, maybe that's not so safe. She can't quite say that about aviation, right? So she can't use 100% the safety issue, although of course, look, there are obviously some risk, but you get a sense of freedom that you're in the air and, you got a full tank of gas and wow, you can just go where you want to, right? It's this incredible feeling. But oddly enough, what got me ready to take the plunge was I started watching the show called Air Disasters. Oddly enough, right? And it's weird. It's weird. It's weird when I say this to you because I just got fascinated by aviation problems and how aviation dealt with it. And one of the interesting things about aviation from a surgeon's point of view is, how aviation looks at complications. And they dissect it so thoroughly, and they have put cameras, videos, monitoring systems in the planes to really dissect what happened when there's a problem. And that focus on reducing complications and safety is why aviation is safe. And we need to do better in medicine in that regard. I am just amazed how we don't have cameras or recordings of our surgeries and what we do and how we act. So I can say and do anything in the OR, and it's like her word against my word. I think really we ought to be more focused on there's something called crew resource management or CRM that we surgeons don't get trained on. How do we train our teams to be effective as a unit, working together to figure out a problem? Or when there is a problem, how do we solve this problem together? We don't get training in crew resource management as surgeons, and we should. So the culture of aviation was fascinating to me, and I learned some of that culture by looking at these air disasters. And, in order to take a plane down, it's difficult. You have to have several factors working against you. You have to have some design flaw or some mishap with the plane, but there's so much safety and redundancy in these planes. You also have to factor in a human error plus some external factor like bad weather. So you have to have those three things to bring a plane down. And I think medicine is often the same way, right? It's not, it's shockingly easy to hurt someone, but at the same time, people are so resilient that there's often a lot of, like when something bad happens, there has to be a couple of things that go wrong in series. And that's what kind of got me interested and got me fascinated about the process of how we in medicine deal with complications and also how well aviation has dealt with it. And I'm trying to bring some of what I'm learning from aviation, especially this idea of crew resource management. How do you get teams to be effective together? That part we don't get training on, like how to work well with others. We don't get training on that as a surgeon.
You know, I'll add an interesting perspective here, which is the first show we ever recorded in the life of Flo. I don't know if you remember, Lucas. Do you remember who?
Was it Tonya?
No, it wasn't. My
Oh
wife
no, it
is
was
a nurse.
yeah, Flight Path.
Yeah, my wife is a nurse, and she and I met at work when I was still covering Texas Children. Well, anyway, St. Luke's, but anyway, she moved down to Texas Children. And one of the things that I loved, because she became a cath lab cardiovascular nurse, became part of that big congenital team, massive team. They do things pretty interestingly enough over there. And they have that problem, right? This is a super complex thing. We're dealing with multiple teams, multiple points of care. And how do we do to, as a system, grow and improve? And so, not that it came from Texas Children, I want to say it came from, it was probably initiated at Toronto Cis Children, but they actually use aviation safety protocols and performance improvement protocols to say, how do we go about making the chain of events in every, from the admit to the throughput to the intra-op to the how do they get to the ICU, how do we look at every one of these variables and create something that helps us fly this plane, this complex array of things where we have all these measurements and things. And so the concept has evolved into what they call performance rounds. And so it is absolutely not an M&M. This is not about he said, she said. It's not about trying to, oh, well, he died because you didn't give blood at the right time. No, no. This is about understanding that at a certain point in time, if a patient comes in with acute the decompensation of their CHF because they have a congenital abnormality, how fast can the echo tech be there to produce the images so that we immediately can call the call team so that the call team is ready to be there on time so that there's absolutely no delay in care and understanding that we have to extubate the patient within certain amount of minutes because we know that the data drives that. And so what they would do is they would just essentially look at these care patterns longitudinally and start identifying areas of improvement. And so there was absolutely no culture of negativity. It was, if anything, where are pain points with the administration in the, because M&M is very clinical, right? It's just doctors and in a way kind of punitive, negative in many facilities, very, very um, draconian in many facilities. But this one was about, okay, hey, you come as the admin guy, you come as a nursing person, you come as a doctor. How do we do to make this go better? And I remember being in awe, listening into the conversations and performance round, and I joined them because I was a vascular surgeon that would help cover cases. And then coming out of that and saying, you know what, I'm going to build a software, and I'll have to show it another day to you, KCO, but I called it the Hope CLTI flight path. And it's essentially seeing how these patients go in and out in from remission, out of remission, CLTI. We look at perfusion, but you realize that everything we do is highly complicated, multiple teams, and longitudinally, right? Because nobody has we don't take gallbladders out where that's it, right? End the story, one and done. We don't take an appendix out and one done. We have a long future with these patients. We know them for years and years, but also how they go into the acute level and how you get them back and land that. It's very interesting. And you are absolutely right that there's so much that we can learn from the knowledge and knowledge base that it almost makes it uh, like every surgeon should probably go to some sort of aviation course of some sort.
I think you're gonna really, I mean, I'll maybe offline we'll talk, but I think you're gonna really enjoy it because I think you already have that's exactly what you're talking about and looking at how you look at problems. That's kind of an aviation mentality, and I think that's why it's safe, and that's why I think it's really interesting and fun to kind of do both because you see it from the same problem or the same types of problems, but from slightly different perspectives. So it's been really fun. Flying's been really fun. I'm 40 hours of flight time, which is about what it takes to become to get your private pilot license. But I'm about to solo, which is I'm a little anxious about that. But that's my next step. In fact, as soon as we're done here, I have a flight lesson.
Oh, that's awesome, man. Well, listen, please let me know if I ever can come on a we just learned this on our last call. If I ever can come on a tiger ride, which is in the Navy when you get to call like your dad to just kind of be on the boat with you and show him how you live your life. That's called uh a tiger run. And so I'll go on a tiger run one day and just be there and just look at it because I would love at some point to seriously look into this, but we'll take that one offline.
Sounds good. Sounds good. It's really
Well,
great talking to you
TCO,
both. I had way more fun than I would have thought.
Oh, that's awesome.
thank you.
That's awesome.
Yeah,
Yeah.
that
Well,
it's a
you'll
very
have to come
intimate,
again.
very fun thing, very immersive,
Yeah,
and may this
yeah.
be the first of multiple. Yeah.
All right. Well, thank you again for the invite.
All
All
right,
right,
we'll let you know
guys.
when it airs, and
Okay.
thank you very much for everything. I'll
Okay.
be seeing a lot more of you.
All right.
Bye bye.
Sounds good. Sounds
Vamos.
good, guys. Take care.